All right. Hello, everybody. So we're going to be here for your week 7 review, dealing primarily with cardio content, but there is some endocrine content in here as well. Here's my number, and please text me or call if you need me. You can also email me. Okay. So, like I said, we're going to start out with the endocrine system. So, list the functions of the endocrine system. And so, just a quick reminder for anybody who hasn't watched these yet, I read the question and then I pause for like 5, 10 seconds. That gives you a chance to pause and write down everything that you can think of and everything that you know. And then you can come back and listen to what I say and compare and add anything to your notes or take away anything. That's the way to use these videos the right way. And I think it'll help you the most. All right. So list the functions of the the endocrine system. So one is going to be to regulate your metabolism. Okay, so your endocrine system is going to be in large part controlling how the body uses nutrients and energy. The second way is in supporting and kind of controlling your growth and development. So a lot of the hormones that we have, they guide things like cell division, tissue growth, sexual maturation. So the next one's going to be 3 is maintaining homeostasis. So remember, homeostasis is just keeping that stable internal environment despite external stressors. And so, way that our endocrine system maintains homeostasis, it does things like balances water levels, electrolyte levels, blood pressure, and then we talked about things like ADH and aldosterone, how they how they can do that, and we'll talk about that a little bit later in this review. The next one we have is the endocrine system will control reproduction. So it regulates a lot of things, like for females, it regulates the menstrual cycle. Males, it'll regulate sperm production. Huge player in pregnancy. 5, so response to stress. So we have the different adrenal hormones we talked about. Like, for example, we got cortisol, we got epi and norepinephrine. Um, Cortisol, both of these coming from the adrenal gland, but this one coming from the adrenal medulla. This is coming from the adrenal cortex. And then the last one really that I could think of, this is definitely not all inclusive. I'm sure I missed some, but this is just the largest ones, is to regulate our circadian rhythm. So we talked about our pineal gland, and our pineal gland secretes melatonin. And so melatonin is used to influence the sleep and wake cycles. And you might have even taken that if you've had trouble sleeping. So like I said, it's probably not all of them, but that's the large majority. So make sure you know those. Discuss the role and function of hormones in the body, including defining what a hormone is, explaining the process by which they bind to receptor sites or specific tissues, and then the 3 mechanisms that control the secretion of hormones. All right, so if we're going to first define a hormone. So a hormone is a chemical messenger secreted by glands or your endocrine glands. So secreted by glands into the bloodstream. And so these hormones are going to act on specific targets and tissues, and these tissues are going to have matching receptors. And then these are going to do all kinds of things like regulate metabolism, growth, reproduction, homeostasis, basically all the stuff that we talked about in the last question. Now, the second part is to explain the process by which hormones bind to these receptor sites of the specific targets. So there is I don't want to say theory, but it's like a proven rule that we use something called a lock and key mechanism when we're dealing with things like receptor sites on specific tissues. So what this is basically saying is that if this say that that's a receptor, the hormone might be shaped like this. And so it's a perfect match. And so that's why it's called a key and lock mechanism. And so whenever we're doing this, there's two kind of different ways that we can have binding. So we have protein hormones, and then we have steroid hormones. So protein hormones are going to do things like activate a secondary messenger. So when I think of secondary messengers, the first one I think of is cyclic AMP. But you can go down and look at well, just look up the mechanism of a protein versus a steroid, and then the words that I'm saying will make a lot more sense. And so these protein hormones, they're typically going to bind on a membrane before they activate. So the binding of the receptor to the hormone on the membrane will cause the activation of this secondary messenger. Then we have steroid hormones. And so these directly, keyword there, directly influence gene transcription. And so these are going to actually be able to go directly inside the cell and directly into the nucleus. And remember, the nucleus is where all your genetic information is. So go directly into the nucleus. So again, just make sure you look up the picture for this. It's in the PowerPoint slides. You can use that. All right, and then explain the three mechanisms that control the secretion of hormones. So there's three different ones. We got one, we've got negative feedback. Two, we've got positive feedback. And three is more just neural control. So for the first one, for negative feedback, this is where the hormone is going, or the release of the hormone stops whenever our desired effect is achieved. So what I like to say is, okay, A plus B creates C. But now let's say, for example, that the production of C to a level of 50 milligrams per deciliter. I'm just completely making that up. But once we've released 50 milligrams per deciliter of C, C will come here and inhibit B. And so because we're inhibiting B, we're not going to be able to move on and not going to be able to create any more C. And so C is being inhibited by negative feedback. And so positive feedback is going to be the opposite. So this is going to be like when a hormone is released, and because it's released, it causes continuous release until that event ends. So what I like to think of is the pregnancy oxytocin birth cycle. And that is a word that I just made up that probably does not exist. But what I'm trying to get at is that, well, actually here. So we already have a high amount of oxytocin whenever we're about to give birth, right? Now, oxytocin causes uterine stretching, or like stretching and contraction. More so contraction. I don't know why I said stretching, but anyway, that uterine contraction causes oxytocin release. So you can see how, okay, oxytocin causes uterine contraction. Uterine contraction, now we're releasing oxytocin. But oh, oxytocin's released, now we're causing more contraction. So you see how it's a positive feedback where the creation of, for example, oxytocin will just cause the event. And so we're not going to stop this event until we have stopping of here. And so obviously once you give birth, your uterus won't need to contract anymore. And so your oxytocin levels will just come down slowly. Then we just have neural control. This one's honestly just the kind of boring one. So it's where like a nerve impulse will stimulate the hormone release. And then just an example of this is like your adrenal medulla. So what will happen is that you'll have some kind of sympathetic stimulation. So whatever that is, and then you have a sharp signal to you, neural signal to your adrenal medulla. Adrenal medulla releases catecholamines. So, oops. So we're thinking epi and norepinephrine. All right, so I know that was a lot. Just reach out if you need anything. And then this is just the chart, in case you do better with charts. All right, discuss the pituitary gland, including the following. So describe the relationship of the hypothalamus to the pituitary gland and describe the location, regulation, and hormones of the pituitary gland. All right. So the relationship of the hypothalamus to the pituitary gland. So what you need to know is that the hypothalamus is the master controller of the endocrine system. So what it does is it will secrete things. So it'll secrete substances that are either blank releasing hormone. You might also see blank stimulating hormone. But you can also see inhibiting hormones as well. Or another way is just through direct neural hormones. And so there's something called the hypophyseal portal system in the anterior pituitary, and that is where we'll be doing things like releasing hormones into the blood. And then your direct neural hormones, that's going to be coming more from the posterior pituitary, where we have actually neurons from the hypothalamus. They're called hypothalamic neurons, and they actually extend into the posterior pituitary, and that's going to be what causes the release. So we got anterior pituitary up here. We've got posterior pituitary down here. That's how each of those work. So the pituitary is usually called the master gland, but the hypothalamus you can think of as like the true boss of what's happening. And then, so if we go down to the next one, so describe the location, regulation, and hormones of the pituitary. So the location of the pituitary gland. So it sits in there's a little spot on your sphenoid bone in your head. It's really very deep. So here's your pituitary gland right here. This small little guy right there. You can see it even a little bit better right here. So it sits in a little part of your sphenoid bone, part of your skull, and it's called the sella turcica. Not really all that important. It's connected by a stalk right here. So we see our pituitary stalk, and then we've got our anterior and posterior lobe. I don't know, I'll just put it on here just in case. So the anterior pituitary is also known as the adenohypophysis, and the posterior pituitary is known as the neurohypophysis. So just in case you see them referred to that way. Okay, so again, location. Sella turcica on sphenoid bone. Deep in the head. So the next one is talking about the regulation. All right, so like I talked about, we have the anterior and the posterior. Oops. We've got anterior pituitary, and we've got the posterior pituitary. So the anterior pituitary, it controls hypothalamic releasing. So it's controlled by hypothalamic. Controlled by hypothalamus release of inhibiting or releasing hormones. So the anterior pituitary is completely controlled by whether or not the hypothalamus gives it a blank releasing hormone or a blank inhibiting hormone. Posterior pituitary, a little bit different. Controlled by neural impulses from the hypothalamic neurons. So just know that the anterior pituitary, that's a portal blood system. So the hypothalamus talks to the anterior pituitary through the blood, releases hormones. Hypothalamus talks to the posterior pituitary through its neurons, neural stimulation. Okay, and then the very last one, I'm going to make a different page for this one because it's a little bit long. So the hormones of the pituitary. So I'm going to start off with the anterior pituitary. Just because it has the most. So a way that you can remember this is flat peg. So the first one we're going to start off with is FSH. So this is follicle stimulating hormone. And so whenever you see this, you should be thinking like the ovaries, the testes, and then more specifically, ovarian follicles for sperm production. So follicle stimulating hormone is you're stimulating the follicles. Next one we've got is LH, and that is luteinizing hormone. And so luteinizing hormone plays a huge role in ovulation. There's also a point, actually a point in the ovulation or the menstrual cycle called the LH surge. And that's where the egg is actually released. So luteinizing hormone, but then also they're releasing testosterone. ACTH or adrenocorticotrophic hormone. I know that one's a mouthful. But what this does is it actually kind of does, it stimulates the adrenal cortex. And what comes out of the adrenal cortex? Hopefully you said cortisol. So our main glucocorticoid. All right, next one we got is TSH. So this is our thyroid stimulating hormone. So I bet you can't guess what that one does. Stimulates the thyroid. It stimulates the thyroid to release its products, which is T3 and T4. Just remember, those are really, really involved in our metabolism. P, we've got prolactin. And so we've got milk production. E is for endorphins. And so, in case you didn't know, this is like a natural pain relief. Whenever you work out, you have a lot of endorphins that are released. Then lastly, we got GH. So that is our growth hormone. So obviously this is involved in things like growth as well as metabolism. And so sometimes people will have a pituitary tumor. I'm trying to think of somebody, I think Andre the Giant did. Don't quote me on that. But either way, if you have a pituitary tumor, sometimes that tumor will push on the anterior pituitary. And if it's pushing on that part, sometimes you have too much growth hormone that's released. If you have too much growth hormone, that can lead to something called gigantism. So that's just one example how tumors can actually, the tumor itself is not actually killing them or doing the harm. It's the tumor is pressing on an area that's causing something normal, but just to a more extreme amount to cause problems. All right, and then the next one we're going to do here is so the next one we got is the posterior pituitary. So I like the posterior pituitary because we're releasing ADH and we are releasing oxytocin. And then another, in case you ever see ADH written out, it's also released as, well, it's called, sorry, vasopressin. So ADH we use for water reabsorption slash blood pressure regulation. The way this works, and again, I know we have not talked about the nephron yet or the renal, so it's completely fine. But what you have is this little area over here called the collecting duct, and ADH will put these little aquaporin proteins in that allows water to just be reabsorbed directly into our blood. And if we're absorbing more fluid into our blood, that'll increase our BP. So something just to think about is if we have increased ADH, I like to think of ADH as the anti-P hormone. So if we have increased ADH, that means that our body needs water, right? Because why else would you be releasing anti-P hormone? And so body needs more water, so you could expect there to be low urine output. And then what little urine output we do have, it should be very, very concentrated because it's going to be a lot of electrolytes and like maybe glucose, for example, but there's not, it's going to, In fact, there's going to be practically there's little to no water because if we have a lot of ADH, we're trying to conserve it all. Then the opposite is true. We have low ADH, means our body probably doesn't need that much water. And if we have low ADH, our body doesn't need that much water. That means that we're not going to be holding on to it. So we're going to have increased urine output, and it's also going to be pretty diluted because we're not holding on to this water. We don't have these proteins right here. And then oxytocin. So oxytocin, also known as the love hormone, but it's responsible for uterine contractions, and then also milk ejection. But just know that it's the love hormone. So I know that was a lot. Identify the other major endocrine glands and their hormones and explain the effects of hypo or hypersecretion. So first one we'll talk about here is our thyroid. So of course our thyroid is responsible for releasing T3 and T4. And T3 and T4, you're going to think about like regulating things like metabolism, growth, sometimes heat production, those things. And so if we have, oh, and then sorry, another one that it also releases is calcitonin. And so remember, calcitonin tones down or brings down blood calcium levels. So there's kind of two different ways that you can go about this. We can have it where it's undersecreted or hyposecretion. So we call this hypothyroidism. And so some of the things that you'd expect to see are like fatigue, weight gain, cold intolerance, bradycardia, so slow heart rate. I like to think of hypo as just think of low everything. So low energy, we got low energy, we got low or high fatigue. We got weight gain because again, we have low energy. A lot of times you'll see a cold intolerance. So they will just be, they'll always be cold. Then I said bradycardia. Or we can have way over secretion called hyperthyroidism. And so another very common name for this is Graves' disease. And so what you're going to think of this for here is that everything is just super high. So our energy is very high. So you might see weight loss, heat intolerance for this one. So we're just feel like we're running hot all the time. Now instead of bradycardia, we have tachycardia. And then another interesting thing is epithalamus. So that's just kind of like where it looks like your eyes are coming out of your head. Look that up real quick if you've never seen it. All right, next one we got is our parathyroid. So remember, if our thyroid is like it's that little butterfly looking thing right on the anterior part of our neck, parathyroid is going to be, if you flip this around, you've got these four little dots. That's our parathyroid. So parathyroid obviously is going to release parathyroid hormone. And the purpose of the parathyroid hormone. So remember, anytime any increase or decrease in parathyroid hormone, the same thing happens to calcium. So anytime it goes up or down, calcium will follow it. And then remember that it's PTH also stands for phosphate traction hormone. So your phosphate levels should go down as PTH goes up. And so, like we talked about, we can have over or under. So if we have hypoparathyroidism, we're thinking things like hypocalcemia, right? Because anytime we have low pH, low PTH, we have low calcium. And so with that comes tetany, muscle cramps, sometimes even seizures. But for hyperparathyroidism, we would have hypercalcemia. So that you're starting to think things like kidney stones, maybe bone pain or fractures even. And our next one, I'm gonna make another page. Our next one here, we've got our adrenal glands. We have our cortex and our medulla, so I'll start with our cortex first. So the main hormones of our adrenal cortex is cortisol and aldosterone. So cortisol is our main glucocorticoid. Aldosterone is an example of our mineralocorticoids. And then it also produces androgens. Not crazy important right now. That'll be more important when we get to repro. But to remember these, just remember the three S's. So we've got sugar, that's the cortisol, we've got salt, that's the aldosterone, and sex for androgens. So with hyposecretion, you get something called Addison's disease. And so obviously this is characterized by low cortisol or aldosterone. But some of the symptoms you have are weight loss, even hypotension. So because remember, if we have aldosterone causes sodium to be reabsorbed, which causes water to be reabsorbed, which raises our blood pressure. We don't have aldosterone, we don't have that. And so we might have hypotension, I mean. Then again, I'm just going to put this, but we just talked about it. So hyponatremia, because aldosterone is our main hormone for that. And then hyperkalemia. And remember, hyperkalemia, you have to watch out for cardiac dysrhythmias. And we've got, you have hypersecretion. So there's actually a few of them, but you might have heard of Cushing's disease. And then some of the symptoms that you'll see are like moon face. They might have a buffalo hump, so right on their back. Obesity, specifically in the trunk region, so truncal obesity, and then very thin skin. So that's some of the symptoms that you should know. And then if we continue on to this, we have the adrenal medulla. And so the adrenal medulla, we have to worry about our catecholamines. So we've got epi, and norepi. Hyposecretion, I'm not really going to talk about that because it's pretty rare. I haven't even really heard of it that much, so I don't think it's real clinically significant. But you also put hypo, but hypersecretion, that will get us to things like something called a pheochromocytoma. And so what this is it's actually a tumor of your adrenal glands, specifically affecting the medulla. And what it does is it causes a super, super sharp increase in the release of norepinephrine and epinephrine. And so obviously this is your main fight or flight hormones, right? So you think everything that happens during that is going to happen, but you could just be like sitting down at your desk. So all of a sudden you could have severe hypertension. You could have heart palpitations. You could start sweating a lot. You probably definitely have anxiety. All of those things that are part of the fight or flight. So that can be pretty dangerous. All right, next one we got is our pancreas. So a lot of people think that it's the pancreas is an organ, but it's actually a giant gland. And so the hormones that we're going to worry about for our pancreas are insulin and glucagon. And I'm going to add one more in case this one's in your book. So insulin is going to be in charge of lowering your blood sugar. And then glucagon is going to be used for raising your blood sugar. And so, so the way this works is that got our blood vessel right here, got our cells, we've got our little doors, and say that this is the glucose, right? What we have is we have insulin that comes in, the little key opens that door, glucose comes flooding into the cell. And then so the problem we have for example, let's just talk about type 1 versus type 2 diabetes. So type 1 diabetes, that is a problem with the key itself. So it has nothing to do with the structure of the insulin. It's just that you have a problem actually synthesizing the insulin and releasing the insulin. And so you can't let the glucose in if you don't even have the key. Now, type 2 diabetes, that is different. This is a problem with the key door match. So type 2 diabetes, it's almost like if insulin is the key, it's almost like you've used the key so much that you've almost stripped the lock. And so now your cells they don't really recognize the insulin as, oh, we need to let this glucose in. And so you don't even have any or a lot of glucose going in. And so it stays in your blood, and that's what causes your high blood sugar. And then sometimes you notice they'll definitely increase thirst just because of the osmolality throw off. But sometimes people also have increased hunger, and you're like, well, that's weird. They have high blood sugar. Why would they be hungry? Well, that's because your cells will actually cause the release of hormones to stimulate hunger. Because think about it, if your insulin is not letting any glucose into your cells, your cells think they're starving because they don't have any glucose coming in. And so they're like, oh crap, we need to start breaking stuff down. And so some people will get more hungry, so that'll release hunger hormones, but also the same principle happens. But they're like, oh, since the glucose can't come in, I guess we need to start breaking down fat. And so if you start breaking down fat, you have to worry about the increase of ketones and diabetic ketoacidosis. And then, yeah, so glucagon will build up blood sugar. So it does this by stimulating, doing things like stimulating gluconeogenesis, the buildup of sugar. And then I've never been asked about somatostatin, but just in case you are, somatostatin inhibits both of these. So it doesn't matter what the role of insulin or glucagon is. If somatostatin gets released, it cancels them out. Okay. Then the next one we got is the ovaries. And so with this one, you have to think of estrogen and progesterone. So with this one, if you have hyposecretion of either of these, you're going to be thinking, so an irregular menses, so definitely an irregular menstrual cycle, maybe even infertility, because estrogen and progesterone play a huge role in the actual oocyte being released, but then also you have you might also have menopause symptoms, because remember that menopause comes from a drop in these. And so if you have hyposecretion, it's essentially the same thing. Now you could have hypersecretion. This is more rare, and so if that happens, you're going to think of menstrual irregularities and think just like anything that normally, so estrogen dominant symptoms are just going to be super, super like high, super polarized is what I'm trying to say. It'll make it worse. All right. Then we've got the testes. And so biggest one for the testes is testosterone. So we have hyposecretion of testosterone. So you might see things like low libido, infertility, decreased muscle mass. And so a lot of guys, especially in their 40s or 50s or even 60s now, they will get testosterone shots to kind of improve some of these things. Or kind of hypersecretion. And so hypersecretion of testosterone, think of puberty. So just think smelly teenagers, but also aggression is a big one, and acne. All right, then we've got the pineal gland. I won't talk too much about this just because we already talked about it, but the pineal gland produces melatonin. And so obviously hyposecretion, you're going to have insomnia because you don't have the hormone that's involved in the circadian rhythm. And then hypersecretion, you'll have excessive daytime sleepiness. So I guess I need to go get checked for I don't know what that would be called, hypermelatonemia. All right, and then we got our thymus. So remember our thymus, the hormone is they secrete thymosins. Just remember that's involved in T cell maturation. So remember they are born in the bone marrow, but they go to the thymus to mature. And so obviously hyposecretion would be a weakened immune system. And then hypersecretion could lead to like for example autoimmune disorders, because you don't want to have too many immune cells floating around. All right, so I know that was a lot. Just kind of think through it, and It'll make sense. All right, so next up we got chapter 15, which is all about blood. Move this. So describe the three functions of blood. So the first function for sure is all about transport. So we are moving O2 from the lungs to the tissues. Okay, so we're transporting oxygen that way. And then in the opposite way, we're taking CO2 from the tissues to the lungs to be excreted as waste. But we also are delivering nutrients. We talked a little bit last week about different hormones that we could be having to deliver. And then also, like we talked about, waste products. And then also, we're transporting heat all throughout the body. And so, when you think of blood, really just think of it like the body's postal service. Like anything that needs to go anywhere in the body, typically you think about just dumping it in the blood and letting it find its way there. Second thing we have is regulation. So we're regulating a few things. So it maintains our fluid balance, right? And then it does that via plasma proteins. So, and we'll talk about this a little bit later, but plasma proteins, they kind of give your blood like a sucking power a little bit, where you can suck fluid in, and that can increase our blood pressure if we need to. And it also regulates electrolytes, which not only electrolytes that gives rise to our acid and base balance, which is incredibly important because remember, if we don't stay within that 7.35 to 7.45 range, our body starts not being able to work real well. Then also another one of the biggest things is body temp regulation. So we can distribute heat that way. And so the blood really just helps to keep the internal environment most stable. Then the last one is protection. So whenever we're thinking of blood, we can think of white blood cells. So we know our white blood cells fight off infection. From some of those white blood cells, we have antibodies. So I'll give you a second. What cell secretes antibodies? So hopefully you said plasma cells. And plasma cells are just mature B cells that are specialized to secrete antibodies. And then we've also got like things like, so for example, platelets. So platelets and a bunch of clotting factors will come together whenever you're bleeding and could possibly save your life. Most of the time, we use them for just simple things like we scrape ourselves or maybe we cut ourselves shaving. But platelets and clotting factors can actually save your life. So blood protects with immunity and also clotting. Okay, so now we're going to describe the components of the blood. So we're thinking erythrocytes, leukocytes, and thrombocytes. What are those? And then explain the formation of blood cells. All right, so our blood has two major components. So it's split up into about 55 and 45%. So about 55% we're thinking is going to be plasma. So you'll find things like water. You might find different proteins. So like albumin, there's some globulins you might find, fibrinogen, that's some examples. We'll also find electrolytes here. Maybe our different nutrients, our hormones, waste, things like that. Then the other 45% are what's called formed elements. And so that formed elements are going to be our erythrocytes, leukocytes, and our thrombocytes. And so whenever we are defining these, I'm going to highlight these. I'm going to do leukocytes in green. I'm going to do thrombocytes in this pinkish color. And then I'm going to do erythrocytes in red, of course. All right. So if we come down here, we've got erythrocytes. So that's these guys right here. That is our typical, what we call red blood cells. And so they're biconcave. That's what gives them, if you looked at an erythrocyte from the side, it kind of looks like this. We have this little divot right here in the center. And there's no nucleus. Red blood cells have no nucleus. But it is packed with a protein called hemoglobin. If you remember, hemoglobin is what is the protein that our blood uses to pick up oxygen from the lungs and then deliver it to our muscles. And so, like we talked about, the primary function of erythrocytes or our red blood cells is to transport oxygen and get rid of CO2, but also transporting hormones and nutrients and getting rid of different wastes. So next up, we have our leukocytes. So leukocytes, these are what we call our white blood cells. And if you remember, they're split up into two different groups. We've got granulocytes, and then we've got agranulocytes, which is really just a fancy way of saying some of them have granules and some of them do not have granules. That's all that word is saying. So granulocytes, we have neutrophils, we've got eosinophils, we've got basophils. And so the way that I always remember this is that, so I have pretty bad asthma, and my grandma, so Gran, used to always tell me to take my nebulizer, and NEB, neutrophils, eosinophils, and basophils. And then on the flip side, we have agranulocytes, and so that's when we're thinking things like our lymphocytes. So that's our T and B cells, and also our monocytes. And if you remember, our monocytes turn into, hopefully you said macrophages. And then the last one we have is thrombocytes. And so these are our platelets. These are what are responsible for clogging. So forming clots, vessel repair, otherwise known as hemostasis. So trying to stop bleeding. The more, I guess, nerdy scientific name that you might also hear this is megakaryocytes. So just know that if you see thrombocytes, platelets, or megakaryocytes, they're all kind of referring to the same thing. All right, and then I'm going to put this last one in blue. So explain the formation of blood cells. So we have a process called hemopoiesis, and this just means blood cell formation. And this occurs in the bone marrow. There's in the bone marrow. And there's two different stem cell lines whenever we are creating blood. There's the myeloid stem cell line, and there's the lymphoid stem cell line. And so if we go down the myeloid pathway, and you can look up a picture of this chart if you want to, like a more detailed chart, but the myeloid stem cells, so we're going to be thinking things like our red blood cells, platelets, our granulocytes, so remember those three, the neutrophils, eosinophils, and the basophils. Then also you can find monocytes over here in the myeloid stem cell line. And then if we go to the lymphoid stem cell line, we're thinking our lymphocytes. So T cells, B cells, there we go, B cells, natural killer cells. That's what's going to come from the lymphoid cell line. And so whenever we're regulating this, so whenever we're regulating hemopoiesis, we use a few things. So we can use something called EPO, erythropoietin, and this comes from the kidneys. And what this does is it stimulates red blood cell production. And then we can also do, so there's things we can put colony stimulating factors. And so what these do is they increase our white blood cell production. All right, so I know that was a lot. Explain the composition, characteristics, and functions of red and white blood cells and platelets, including the breakdown of red blood cells and the formation of bilirubin. So just a real quick, what we just talked about. Another name for red blood cells are erythrocytes. So if we start there, I'm not going to write erythrocytes every time. I'm just going to start putting RBCs, but just know that what I'm talking about. So red blood cells, erythrocytes. So what do we know? So we just learned that they are biconcave discs. So that's what gives them their shape that looks like kind of like that. We just saw that they have no nucleus. They have a ton of hemoglobin. And their membranes are pretty flexible because they have to allow for capillary passage, right? So remember, we go from an artery to an arterial and then to a capillary. And so our blood gets pushed in this tiny little area. And so we need to be able to have a membrane that can go from like this to easily like this so that it can pass through. So it's really, really stretchy. And then just because I've seen this come up in a few exams in my life, the time span, they live about 120 days. So about 4 months. And then we talked about the functions. So the function of red blood cells is transport. It is the body's postal service. Anytime we need something to get delivered somewhere, or we need something picked up to excrete, it's going to be going through the vascular system. And next up, we got our white blood cells. So uniformly referred to as our leukocytes. Same thing for these ones. I'm just going to put WBC for white blood cells. So what's important about these is that our white blood cells do have a nucleus. And they are quite a bit larger than our white blood cells. These can leave our bloodstream, no problem. So typically if blood is leaving our bloodstream, it's almost, I can't think of any situation where it would really be a good thing very much. But white blood cells can do this pretty easily through something called diapedesis. But whenever we're talking about our white blood cells, we have Again, we've got two basic groups. So we've got granulocytes and agranulocytes. So remember, neutrophils, eosinophils, basophils. Agranulocytes, you're thinking T and B cells as well as monocytes. So just remember, granulocytes have granules, and so if you the neb doesn't work for you, kind of intuitively think what kind of cells would have granules. So do neutrophils need granules? Yeah, because they have to have a bunch of um, things like different proteins, different enzymes and stuff so that they can fight infections, right? And they have to have a way to hold and store all these things. Eosinophils, we know eosinophils are very, very active in allergic reactions. And eosinophils, along with mast cells too, but they're not granulocytes, but mast cells will secrete histamine, and then so will basophils. All right, so identify the steps in hemostasis. So hemostasis is the process of stopping bleeding. Then there's kind of three major steps. This one says four. It's really just a matter of what you're reading. You're not going to get asked like, oh, what's the first, second, third, or fourth? You more just need to know intuitively what happens, and you'll be fine. So the first thing we have, or the first step, I should say, is a vascular spasm, also known as vessel constriction. Basically, it's just where your vessel will strongly constrict. So vasoconstriction, that's supposed to be a D, due to blood vessel injury. And so what this does is it reduces our blood flow to the area because we don't want to bleed out. So that prevents reduces blood flow, but it also prevents blood loss. And typically this is going to be triggered by our pain receptors. It also can be like smooth muscle injury, local chemicals that get released upon getting hurt, any of those things. But just remember that your body's first response to getting an injury like this and stopping the bleeding is to strongly vasoconstrict. Second part we have is forming our platelet plug. And so platelets are going to stick to this very, very exposed collagen. So right here, you'd have exposed collagen. And what we're seeing in this picture right here is that these little activated platelets via positive feedback. So we talked about what that was. It forms this temporary platelet plug, and this platelet plug at least keeps the blood inside of your blood vessels. And then the last step that we have here is coagulation. So this is where the blood is actually clotting, and there's a very, very like complex cascade, but it involves activating fibrin. And what happens is these threads of fibrin, they form kind of like a mesh, and it stabilizes that platelet plug. And then what happens is your body creates a stable clot to seal up the vessel. So just remember that fibrin is the net that seals the wound. So that's what you're seeing right here. All right, and then now we're going to describe the four blood types. So our four blood types that we've got A, B, got AB, and we've got O. So we're going to go through each one kind of one by one. So group A, the antigen that's on the red blood cells. So the antigen that's floating around on every single red blood cell is the A antigen. And so people in this group, they have group A blood or type A blood, the antibodies that are found in their plasma are anti-B. And that makes sense, right? Because if their body sees something that comes in that has B antigens on it, their body's going to be like, okay, this is foreign. We need to destroy it. So there's a reason we have these, but it can cause problems in our new advanced age of transferring blood. And so they are, let me see, I want to add another. I'll add another page here. So I'm going to add one little box here. So if you're type A, you can receive two types of blood. You can receive type A or you can receive type O because type O, as we'll talk about, has no antigens on it. So if you have no antigens, then there's nothing for your body to attack. So group B, that's going to be the same thing as A, except the roles are a little bit reversed. So we've got B antigens here on all of our blood, and we have anti-A floating around because we want our body to recognize we want our body to recognize A antigens as foreign. And so we have the B antigen, like I said, floating on all the red blood cells. And so the types that B blood can receive are B and O. And you know what? Just because we're doing this, why not? We'll add one more. And then can donate to. So if we're going back to type A real quick, type A can donate obviously to other type A's because everything's compatible, but they can also donate to AB. And then same thing for B, except it's B and AB. So why can A and B not donate to type O? Because type O has anti-A and anti-B antibodies. And so as soon as you put either type A or type B blood into somebody with type O, their body's going to be like, oh my gosh, it's foreign. We need to destroy it. We need to destroy it. And then you'll have vast hemolysis. And that's not good. So the next one, AB. So people with AB, they have both A and B antigens on their blood. And their antibodies, they have none. So they don't have any anti-A or anti-B. And so these group AB or type AB, these are sometimes referred to as the universal recipient. That's because they don't have any antibodies, and so they can receive from literally anybody. They can receive A, they can receive B, they can receive AB, they can receive O because they don't have any antibodies that are going to recognize this as foreign and destroy it. And like I said, they have A and B antigens on their red blood cells. Now, here's the thing that kind of sucks for them is that the people that they can donate to is only AB. Because think about it, everybody else has, or everybody else, I mean, everybody else in these groups has either anti-A, anti-B, or both. And we have both on our red blood cells. So if they receive from, or if they donate to anybody else, their blood is going to be attacked. But they can receive from anyone because there's no antibodies. And then this last one we have is type O. They have no antigens at all. No antigens. But they have anti-A and anti-B antibodies. So if they receive from anybody except type O, they will have a hemolysis reaction, transfusion reaction. Now on the flip side, like AB was the universal recipient, group O is referred to as the universal donor. Because even though they can't receive from anybody except O, because they don't have any antigens, there's nothing for other people's bodies to attack. It's just a kind of like a naked red blood cell, I guess. And so they can donate to anybody, A, B, or O, because these doesn't matter if you have these antibodies if there's no antigen to attack. So hopefully that made sense. If not, come talk to me and we'll make it make sense. Okay, and then describe the Rh factor. So first off, what even is the Rh factor? So the Rh factor is just an antigen on the surface of red blood cells, so not really all that different than what the A or B antigen is. This one is specifically called the D antigen. And so you probably guessed if you have the antigen on your blood cells, you're Rh positive, and if you don't, you're Rh negative. And so people who are Rh negative, they typically do not naturally just have anti-Rh antibodies floating around because they have to be exposed to Rh positive blood so that their body can create these antibodies. And so this entire process where they only form the anti-Rh antibodies after they're exposed to that Rh blood, that's called sensitization. Sorry. And so as far as transfusions go, Rh negative patients, they cannot receive Rh positive blood after they've already received it. So these have the D antigen already, which means they have Rh antibodies. Rh negative people do not have anti Rh antibodies. So the key point here is that if you're Rh negative, you must be exposed. You have to be exposed to Rh positive blood in order to develop the antibodies. And so here is where the problem lies. So say we have a mom and she is Rh negative. So her red blood cells do not have the D antigen on it. I say that their kid or her child, see, how am I going to do this? Good enough. So even though she's Rh negative, say her child is Rh positive. Now, through just natural blood mixing, but also delivery, pregnancy itself, just the mixing of blood in general, because she has an Rh positive child, she will start to develop Rh antibodies. Now, this is not a problem, right? Because the child's going to be born. Oops. The child's going to be born. And even though they're Rh positive, they're still Rh negative. Everything's good, except the difference is we have, she's Rh negative, but we have antibodies now. And so everything would be fine if they only had one child. The problem is this process right here, which is sensitization. That's the word I was trying to say before. Because we have this, where now she has Rh antibodies, if she gets pregnant again, so I'll put, if she gets pregnant again, her maternal anti-Rh antibodies that she's made because of that first birth, they're going to cross the placenta. And so that's going to lead us to something called HDN, which is hemolytic disease of the newborn. And so this is where basically the maternal anti-Rh antibodies, they just attack the fetal red blood cells. And so it leads to hemolysis. That's a big problem. We're lysing blood cells, anemia, jaundice, heart failure, and then in the most severe form, you can get something called erythroblastosis fetalis, and that's where the baby dies. And so I'm not going to write all this down because it's not all that important for you, but later on it will be. So mothers who are Rh negative, they can receive something called RhoGAM, and they can receive this during the pregnancy and then actually after the delivery. And so what this does is RhoGAM destroys the fetal cells that are Rh positive. And so when you destroy these, it prevents the mother obviously from creating antibodies because you're getting rid of this blood. And so it prevents that process of sensitization. And so if you prevent that, then you're preventing hemolytic disease of the newborn. And so you definitely won't have erythroblastosis fetalis if you're preventing this in general. This. Okay, and then next up we've got chapter 16, which covers anatomy of the heart. So for this first one, describe the location of the heart. So it's positioned in the thorax, so it's located in the thoracic cavity, and it sits right in something called the mediastinum, and it's the central compartment right in between the lungs. And then specifically, the heart sits right in the middle mediastinum. And then, so just the way that it's kind of orientated, because I'm not sure, we probably talked about it, but just in case, the base of the heart is the top of the heart, and it kind of points toward the right shoulder. And we've got the apex. The apex is the bottom of the heart. And so that points downward and left, and it kind of rests right on the diaphragm. And then, so roughly like 2/3 of your heart is actually um, to the left of the midline. So that's why, like if you really feel your heart pumping, it's usually just slightly left. Okay. So name the three layers and the coverings of the heart. Okay, so first up, we've got the endocardium. And so this is the very thin, very inner layer of our heart. It has thin, kind of smooth epithelial lining, and it's continuous with the lining of the blood vessels. And so the whole purpose of this is to reduce friction and hopefully prevent clot formation. So endocardium, then inside lining. Then the myocardium, so that's going to be your thickest layer right here. So this very wide area. So that's made of all cardiac muscle, and it's responsible for the pumping action of the heart. So all that, because think about how much power your heart has to have to pump the blood to the rest of the body. So it's all that muscle in this myocardium. Then you've got the outer layer. So the epicardium, that's going to be the outermost layer of the heart. Sometimes people call this the visceral pericardium. So just in case you see it referred to as that. So this is really the function is to provide protection, and it also secretes like a serous fluid. So that's from this angle, and then this is from the side. So really just make sure you realize like how thin the endocardium is. So we've got this giant layer right here. That is all myocardium. We've got your epicardium right out here. And then just because we're talking about the very outside layer, so The pericardium so pericardium is a double layered sac and it surrounds and protects the heart. And so we have the fibrous pericardium, which is going to be the tough outer layer. It's this one right here. That's the tough outer layer. What this does is it kind of anchors the heart. Then we have the parietal pericardium right here, and that lines the inside of the fibrous layer. Then we've got the visceral pericardium or the epicardium, like we talked about, and that adheres directly to the heart surface. And then if we have all that, then we have this little area right here that's called the pericardial cavity. So this is the space between the parietal and the visceral layers. We had sort of the same type of thing. If you remember in the lungs, we had the pleural cavity. Then we had the visceral and parietal pleura. So we have the pericardial here, pericardial cavity, and it's filled with serous fluid. And again, the purpose of the serous fluid is to reduce friction. If this thing is pumping all the time, you don't want structures rubbing up against each other. You don't want friction. Okay, explain the function of the heart as two separate pumps. So what they mean by the heart as two separate pumps is that there's two pumps in one organ. Both of them serve a completely different circulation. So the right pump, actually, let me just go ahead and color code this real quick. So I'm going to use blue because the right side is carrying deoxygenated blood. So the right side, this is known as the pulmonary circuit or the pulmonary circulation. And like we said, this is responsible for pumping deoxygenated blood to the lungs because that's where they go to get oxygenated. And so when we're thinking about the right side, the right pump, the flow path is so we start in our body, right, in our venous system, and we have all of that pumped either by the superior or the inferior vena cava gets pumped to the right atrium. And so remember, that's called our preload, the amount of blood that's pumped into our right atrium. Then from here, we have our right ventricle. And then from our right ventricle, we have our pulmonary artery. And remember, this is the only artery in the body that's going to be carrying deoxygenated blood, but it's still called a pulmonary artery because the blood is still going away from the heart to the lungs. So that's why it's called an artery. And then finally, we get to our lungs. And then just to add, just for completeness sake, we have our tricuspid valve and our pulmonic valve. So the entire purpose really is gas exchange. So we're going to be dropping off CO2 and picking up O2. So this is a generally pretty low pressure system. The right ventricle has a pretty thin wall, taking short distance pumping here. So just from the heart to the lungs. Okay, then we have the left pump. So this is known as the systemic circuit or systemic circulation. And what we're doing here is we're pumping blood that has a lot of O2 to the entire body. So to our tissues, and to our different organs. And so the flow path for here is that we're basically picking up where we left off right here. So I'm going to put 5 starting in our lungs. So now that the blood has gotten to our lungs and our lungs fill our blood with oxygen, the next step is for us to enter our pulmonary vein. And likewise, as the pulmonary artery is the only one that has oxygenated blood, this is the only vein that's going to have oxygenated blood. And from the pulmonary vein, we enter our left atrium. And we hit our left ventricle. Bonus points if you remember the valve. So this is our mitral or our bicuspid. And from here, we have our going to our aorta, and hopefully you said the aortic valve. And then from the aorta to the body. And then we pick up here like that. So it's 2 different pumps. But if you think through it logically, it should make a lot of sense. And so just know that the left side is a high pressure system. We've got this thick wall right here in our left ventricle. And so that's what makes it possible to pump long distances and against resistance. But you have to have both of them because you have to keep these 2 systems separate. You have to keep deoxygenated blood in one system and oxygenated blood in the other system. And so because you want to ensure that you have efficient gas exchange in the lungs and then strong perfusion to the tissues. Okay. Identify the 4 chambers and the great vessels of the heart. All right, so what you have here on this side, this is a real cadaver heart. And so this first chamber we have right here, we have our right atrium. So this is where we would have our inferior vena cava and our superior vena cava dumps our deoxygenated blood first off into our right atrium. And so this is what they're referring to when they say preload. Right, and if we keep traveling down right here through this valve, which would be which one? So hopefully you said the tricuspid valve. We get to our right ventricle. And so remember, our right ventricle is where we're going to be pumping deoxygenated blood to the lungs. And before the lungs, we hit our pulmonary artery through our pulmonic valve. And then once we make it to the lungs, we come back here through our pulmonary vein. We get to our left atrium, and so that's going to receive oxygenated blood from the lungs. So we're coming back here. We have oxygenated blood here. Then we have our mitral valve. It's called the bicuspid. And we make it into our left ventricle right here. And so just really quick, notice the right ventricle, this is the thickness of the wall versus how thick the left ventricle is. Because this is the systemic circuit. So you need more muscle mass to push all that blood. And then so we had the left ventricle, and this is going to be responsible for pumping blood through the aortic valve to the aorta and then to the rest of our body. All right. Then real quick, if we're just talking about the great vessels of the heart, so we've got the superior and inferior vena cava. So these are what is returning deoxygenated blood to our right atrium. Superior vena cava bringing blood from our upper half of our body, and then inferior vena cava bringing blood from the lower half of our body. Then we've got the pulmonary trunk and the pulmonary arteries. So these exit at the right ventricle. So this is one of our pulmonary arteries right here. And these are going to be carrying deoxygenated blood to our lungs. Again, remember, this is the only arteries that carry deoxygenated blood. Then coming backwards, you can't really see it all that well, but you have your pulmonary veins. So only veins that carry oxygenated blood. So we have oxygenated blood returning to our heart from the lungs this way. And then we've got our aorta right here. So this is the largest artery in the body, and it exits the left ventricle. So right there. And it's going to distribute oxygenated blood to the systemic circulation. Okay, explain the function of the 4 heart valves. So the first one we have is our tricuspid valve. And so this is if you're looking at the heart. So say we have our heart right here. This picture is if you were looking down at the heart like this. So first of all, we have our tricuspid valve. So we know that because we have our 3 leaflets right here on the valve. So our tricuspid valve is between the right atrium and the right ventricle. And what it does is it prevents backflow back into the right atrium. Because if we had too much backflow, remember we start getting things like JVD, jugular venous distension, where our jugular vein has so much blood backed up that you can see it pooling. And so it just ensures that blood keeps moving forward into the pulmonary circuit. Next one we have is our pulmonic valve, right here, or our pulmonary valve. And this is between our right ventricle and our pulmonary trunk. And so what we're doing here is we are, again, preventing backflow, this time into the right ventricle after the ventricles contract. But it also allows blood to enter the pulmonary arteries to go to the lungs. Okay, next one we got here is the mitral valve. Let me put it right here. So we've got the mitral valve. So this is going to be between the left atrium and the left ventricle. And once again, we want to prevent backflow. But this time preventing backflow into the left atrium during left ventricular contraction, because remember, if we have backflow into the left atrium and then we start getting congestion, we start getting pulmonary congestion because it keeps backing up and backing up more and more. And then this last one here is our aortic valve. So this one, you're going to be able to find this one between the left ventricle and the aorta. And so again, we are preventing backflow, this time into the left ventricle. And it allows blood to enter the systemic circulation. But I just want you to notice the very, very common theme here: preventing backflow. Oh, and then real quick, let me just note these are your AV valves, and then these two are your semilunar valves. AV standing for atrioventricular, because both of these are right in between the atria and the ventricles. Okay. Describe the physiological basis of the heart sounds. All right, so our first one we have is S1. So this is our lub sound. And so what's causing this lub is closure, closure of our AV valves, so our mitral and our tricuspid. And more specifically, so this starts at the start of systole. So ventricular contraction, that's whenever this one is going to start. And so it happens because we have that ventricular pressure that's rising at the start of systole, and because of that, when our ventricles rise in pressure, the AV's valves kind of slam shut. So what you're seeing is that our ventricles are contracting, and when they contract, it slams these valves shut that way. And so the blood kind of briefly vibrates against these valves and the wall, and that's what we're hearing. So when you think S1, think low pitched sounds. Typically, it's going to be longer, a longer sound, and then it's loudest at the apex. All right, we've got our S2 sound. So like we've got here, this is our dub sound and the lub dub. And what you're hearing here is closure of our semilunar valves. And so this occurs at the very start of diastole. So what you're seeing is that your ventricle pressure falls. So we have our ventricles that are expanding like this. And because of that, these valves slam shut. And so the blood kind of rebounds briefly, but that vibration is what you're hearing. And so the S2 sound is typically described as higher pitched, typically going to be shorter, and this one's loudest at the base. So those are the physiological slash normal. And so sometimes you can have extra hard sounds. I'm going to put these in blue. So we can have S3. And this, the cause of having an S3 sound is its rapid passive filling of the ventricles pretty early in diastole. And so what causes this is the blood is hitting compliant or dilated ventricles. And so I was told S3 have to pee because oftentimes in like if you have blood overload, your ventricles will become compliant or dilated because they're having to pump against all that extra fluid all the time. So they become more compliant. And so S3 have to pee because you are fluid overloaded, and that causes dilated ventricles. So it's pretty normal in people like children, athletes, sometimes pregnancy, but in adults, sometimes it can be a sign of heart failure. So think S3, think early filling, but mostly think fluid overload. Then we've got S4. And so what this is an atrial contraction. But what's happening is the blood is hitting a very stiff, non-compliant ventricle. And so the mnemonic for this one is S4, slam the door. Because what we're dealing with is a very stiff or non-compliant ventricle. So typically you're going to see this in times like hypertension or left ventricular hypertrophy. So that's where the muscle gets really, really thick right here. And so that's actually what you're hearing. It's blood hitting this valve. Yeah. So that's the physiological heart basis of sounds, of heart sounds. Sometimes you will have somebody with what's called a heart murmur. So what this is, it's turbulent blood flow. So there's two different kinds of blood flow. We have laminar blood flow, and that's where you have just a healthy vessel, blood is moving through, really can't hear it. Turbulent blood flow is where we have something that causes the blood to hit and be rebounded. This is what you're hearing. This is turbulent. And so that's what a heart murmur is. So usually it's turbulent blood flow due to things like stenotic valves, maybe any kind of regurg that you're hearing, sometimes septal defect, things like fever or pregnancy that can sometimes cause it. And so if you don't like the way that we talked about the valves, I have a little chart here for you if you like that better. All right, so describe blood flow through the heart. So just do this real quick. So we're starting on the left side. So we're starting with deoxygenated blood. So we first hit the superior and the inferior vena cava. So superior vena cava is going to be carrying blood from our upper body, inferior from our lower body. So from the superior vena cava, next stop we hit, I'm trying to find it. It's not labeled. Okay. So the next step is our right atrium. It's not labeled, but it's right here. Our right atrium. And from our right atrium, we hit our tricuspid valve. And remember, tri before you bi. Tricuspid before your bicuspid. Tricuspid valve, and then into the right ventricle. And now they don't have it marked, but we have our pulmonic valve next. And then as we go through our pulmonic valve, we enter our pulmonary arteries, specifically pulmonary arteries. And once we go through our pulmonary arteries, we would have our lungs right here. So we go to our lungs, oxygenated. We enter our pulmonary veins, specifically our pulmonary veins, going to our left atrium. And from our left atrium, we hit our mitral valve or our bicuspid. Then we hit our left ventricle. Then we hit our aortic valve right here. And then lastly, we hit our aorta. All right. List the vessels that supply blood to the heart. All right. So first of all, the vessels that are supplying blood to the heart, these are known as our coronary arteries. So these are the arteries that provide blood to our heart. And so we have our aorta right here. And off of our aorta, we have two branches. It comes off like this. So this first one we have is our left coronary artery. Right here. We have our left coronary artery. The other branch leads us to our right coronary artery. So the major branches of the right coronary artery is you have the right marginal artery. And you also have the PDA, so the posterior descending artery or the posterior interventricular artery. And so the right coronary artery is going to supply things like the right atrium, the right ventricle, both of our SA and AV nodes. So remember, those are both important. And then part of our left ventricle. Now our left coronary artery. So this one's going to split pretty quickly. So it's going to split. We have one right here, our left anterior descending artery. They have that one marked, and then they have this one over here, and that is the circumflex. Circumflex artery. This one right here. And so our LAD, our left anterior descending, is going to supply our anterior left ventricle, our interventricular septum, and like our bundle branches. And so the LAD sometimes is referred to, like if there's a heart attack, it's a widowmaker. And that's because it feeds the front left ventricle. So think about what happens if you start getting a necrotic or dead left ventricle. You're not able to pump blood to the rest of your body. Identify the major components of the heart conduction system. So our first step is our sinoatrial node right here. It's in like our upper right atrium. And so this is the primary pacemaker. Our primary pacemaker. And so it's going to keep our heart within 60 to 100 beats per minute if it's healthy. That's sinus rhythm. And so this is what's going to actually initiate each beat. Next up, we have our AV node. And so this is our backup pacemaker. So we're going to keep our heart rate at 40 to 60 beats per minute. And just know that between the conduction between the SA node and the AV node, we have a very slight delay. And that delay is important because it allows for full ventricular filling. So it looks like a beat, then we have a slight delay, pumps all the blood, lasts a little bit out, and then boom, beat, and it beats there. Okay, then after we have that, we have the bundle of His. And so that's going to be conducting the impulse from the AV node into the ventricles. So it's this area right here. That's the bundle of His. And so it's the only electrical connection really between the atria and the ventricles. And so I like to think of the bundle of His as like a bridge to the ventricles. Then we have our left and right bundle branches a little bit further down right here. And so that travels down this area right here. And this space right here is called the interventricular septum. It's responsible for carrying impulses to each of the ventricles. Then if we keep going down, we have our Purkinje fibers, which is right here. So it's spread throughout both of our ventricular myocardium. And this causes coordinated ventricular contraction, which is what you want. You want both the ventricle to contract at the same time. These have an intrinsic rate of 20 to 40 beats per minute, so they might be able to keep you alive, but not how you'd want to be. So just real quick, the full pathway is our SA node to our AV node, from our AV node to our bundle of His, from our bundle of His to our left and right bundle branches, and then from here to our left and right Purkinje fibers. Okay, and then lastly here we have chapter 17, functions of the heart. So define the cardiac cycle with respect to systole and diastole. So the first starters, the cardiac cycle is complete one complete heartbeat. So there is consistent and coordinated periods of contraction, which is systole, and relaxation, which is diastole. So we're going to start off with, let's start off with diastole. So we have there, it's the relaxation. So this is where the atria and the ventricles are going to relax. So we have relaxation of the atria and the ventricles. But something else important that happens is that your AV valves open. And so remember that's your tricuspid and bicuspid or mitral. So because we have our AV valves open and our ventricles are relaxed, that's going to allow for blood to flow passive. Because now not only have we opened the door to the ventricle, but we've made the ventricles bigger. So this is the prime opportunity to send blood into it. So we have that passive filling. And then after we have that passive filling, the atrial contraction sends out that little bit extra blood that might be left. Just to make sure that we get all of it. And so the purpose of diastole is to fill the heart chambers with blood. And then something else that's just kind of important is that your coronary arteries, so remember, that's the arteries that are supplying your heart with blood. This is the stage in which their blood flow is maxed. So they receive most of their blood flow during this phase. Okay, and then the next one we have is systole. And so what happens here is we have the ventricles, let's say, of the ventricles. And so what happens here is we have the AV valves closing, right? Because if we're thinking through this logically, if our ventricles are contracting but our AV valves are open, it's just going to send blood. So here, we draw this right here. So if our AV valves are open right here, as soon as our ventricles contract, it's just going to send blood this way. So these AV valves need to be closed so that blood can stay on its path. So the AV valves closing, this is where we hear S1. And then obviously if the AV valves are closing, then the semilunar valves are always going to be opposite. So the semilunar valves are going to be open. So that's our pulmonic and aortic. And so what we get with this is that blood is ejected into the aorta and the pulmonary arteries. So the lungs, or I'm sorry, the right ventricle pumps blood during systole to the lungs, left ventricle pumps blood to the rest of the body during systole. All right, describe the autonomic innervation of the heart, including sympathetic and parasympathetic innervation. So the heart is controlled by the autonomic nervous system. And so just real quick, because I know it's been a minute, our nervous system can be broken down into two areas. So we've got our CNS or PNS, so our central nervous system. That's our spinal cord, spine slash brain. The peripheral nervous system is literally everything else. Now, the peripheral nervous system can also be broken down a little bit further into our somatic nervous system or our autonomic nervous system. And then our autonomic nervous system can be broken down into sympathetic and parasympathetic. And so what we're looking at here is our sympathetic and our parasympathetic. These are going to be what's regulating things like heart rate, conduction speed, contractility, based on what your body needs. So remember that our sympathetic, that's going to deal with things. We've got our sharp increase in epinephrine and norepinephrine. So our symptoms are going to be that of fight or flight. This one's going to be rest and digest. And so whenever we think of what happens for each of these, if we have the sympathetic innervation coming to our heart, you're going to think things like increased heart rate, increased conduction speed, increased contractility. So not only are we going to be beating faster, but we're going to be beating harder. So this is called inotropy. And then if you remember from last week, this is going to cause increased stroke volume and increased cardiac output. So all of these things are part of our fight or flight. So like if you see a bear, you're going to want to have increased heart rate because you want your blood pressure to be able to be at a point where you can maximize tissue perfusion. You want to increase the conduction speed. You want to increase contractility because you want an increased stroke volume and increased cardiac output because you want more blood to be going to your oxygen if you're running, or to your body if you're running from a bear. Whereas we have the parasympathetic nervous system, and that's going to be pretty much the exact opposite. So just remember real quick that the main parasympathetic nerve is our vagus nerve. So that's cranial nerve 10. And so basically, your vagus nerve can get stimulated, which stimulates something called the cardiac plexus, and that stimulates our heart. And so what we'll have here is we'll have decreased heart rate, because if we're just resting and digesting, we don't need to have an increased heart rate. Increased conduction speed. There's not really that much of effect on contractility, honestly, because you don't really need to know this, but they lack really strong parasympathetic fibers. So, but just remember that again, all of this is part of rest and digest. And so usually your heart rate is going to be dominated more by your parasympathetic, like during times of stress or exercise. That's whenever your sympathetic system will kick on. But both of them are having to be constantly adjusted to maintain homeostasis. So if this was kind of hard or you didn't like the way that was explained, here's a chart for you. So sympathetic, you have all the effects that you would expect. Norepinephrine, just remember epi is also here. Okay, and then define cardiac output, including the following. So describe the effect of Starling's law on the heart, describe the inotropic effect of cardiac output, and then explain how the changes in the heart rate and stroke volume can change cardiac output. All right, so first off, let's define cardiac output. So if I did it via formula, cardiac output is equal to stroke volume times heart rate. So think about this real quick. Cardiac output, which is the amount of blood that's pumped out of the ventricle per minute. In order to find this, we have to have the stroke volume. And so stroke volume is the amount of blood that's going to be pumped per cardiac contraction times the heart rate. So basically it's how much versus how often. And both of these will give you how well your heart is functioning to pump blood out. And so whenever we're referring to Starling's law of the heart on cardiac output, he discussed things like if you have increased venous return, so say that your veins are returning more blood, that means that you will have increased ventricular stretch. And this is also known as preload. So remember, preload is the amount of blood that's returning back to your heart. And so keeping this in mind, if we have more stretch, so more blood causes more stretch, your your body's going to know, okay, that means I need to have a much stronger contraction because I've got more blood. And so stronger contraction gives us a stronger stroke volume, right? Because we're pumping more out. And so therefore, increased stroke volume will have an increased cardiac output. And so that's what inotropy is. Inotropy is just the change in contractility. So because we increase the stretch, because we have more blood, our preload's bigger, that increases our contraction or our inotropy, which increases stroke volume, and that increases cardiac output. And then explain how changes in heart rate and or stroke volume changes cardiac output. So let's just do both. Let's do heart rate. We'll do increase and decrease. And then we'll do just stroke volume. Increased and decreased. So first one, we have our heart rate that increases. So if our heart rate increases, how is that going to change cardiac output? So if we're increasing our heart rate, that means that we're putting out more blood. So our cardiac output is going to increase to a point. But the reason I say to a point is because whenever you have a very high heart rate, you're giving your blood, or you're giving your chambers, your heart chambers, less time to fill. And so, in a way, that would decrease your stroke volume and decrease your cardiac output. But to a point, the more your heart pumps, the higher your cardiac output is going to be. But just know that if it gets to be very high, like over 160 to 180 beats per minute, then that kind of your cardiac output will actually go down. Now, if you have decreased heart rate, that's going to lead obviously to decreased cardiac output because um, you're not pumping as much, and so sometimes you can have moderate bradycardia. Like for example, some people who are really really athletic, their resting heart rate will just be lower, and so sometimes that moderate bradycardia is compensated by an increased stroke volume. But just know that in general, this is the trends. And then stroke volume. So stroke volume, remember, stroke volume depends on preload, so the amount of blood coming back to your heart. Afterload, the amount of resistance that your ventricles are feeling whenever they're trying to pump blood. And then your contractility, so how well your heart is contracting, also known as inotropy. So with increased stroke volume, we will have increased preload and increased contractility. Both of those will lead to increased stroke volume. Now, if we have a decreased stroke volume, typically going to be from things like decreased preload and decreased contractility. And so if you increase the afterload, you're going to be decreasing cardiac output because this is just increasing resistance. So any more resistance is going to be harder for your heart to work. This one's the opposite. Decreasing afterload means you're going to have less resistance to push against, and so that will increase your cardiac output. Okay, define the specific clinical vocab used to describe cardiac function. So we're defining preload, afterload, chronotropic, inotropic, dromotropic, and how it affects cardiac output. So I was kind of referring to this in the past couple questions, but preload is going to be the stretch of the muscle, the ventricular muscle at the end of diastole. So how much blood is being returned to the heart? That is preload. We have our heart right here, got our chambers. The amount of blood that the superior and inferior vena cava brings into the right atrium, that's your preload. And so how preload affects cardiac output is that if you have an increased preload, so you have more blood flowing back to your heart, that's going to increase the amount of stretch that your heart is feeling. And that increased stretch is going to increase your inotropy, which is the amount of contraction. So with that, we have increased cardiac output because our heart's beating faster. And so now if we're defining afterload, afterload is the resistance that your ventricles feel when ejecting blood. So for example, we have our heart, our chambers. Your right ventricle is going to pump blood this way. But because our arteries can vasoconstrict and also because there's so much, there's going to be a force that's counteracting it this way. And our ventricles have to be stronger than this force. They have to overcome it to pump blood to the rest of the body. That force, that is your afterload. And so, how does afterload affect cardiac output? Well, if we have increased afterload, that's going to mean it's going to be harder to eject blood. Okay, if it's harder to eject blood, you're going to have a decreased stroke volume because it's not as much as going to be able to be pumped out. And because you have a decreased stroke volume, you have a decreased cardiac output. So chronotropic, that deals with rate, so your heart rate. And then dromotropic is referring to conduction speed. So, for example, sympathetic stimulation causes increased dromotropic effects, and that's how fast your heart is conducting. All right, then we got our last one here. So, define heart failure and differentiate between the two kinds. So, right and left heart failure. So, heart failure, our main problem is that the heart cannot pump enough blood to meet the body's needs. Our body needs blood and our heart's not able to do it. So this can be from a lot of different things. So maybe impaired filling. So we're not filling our chambers right with blood, or it could be impaired pumping. So impaired filling, that's known as diastolic failure. Impaired pumping, that's known as systolic failure. And the problem is this leads to congestion, so pulmonary congestion, um, or systemic congestion, poor perfusion, or both sometimes. So let's start out with left-sided heart failure. So with left-sided heart failure, our chambers right here, we're looking at this side failing here. And so most often what happens is we have a left ventricle that fails. And remember, our left ventricle is what's going to be pumping blood to the rest of our body. And so if we're not pumping blood, it's going to build up in the ventricle, then it's going to start building up in the atria. And now the big problem that start backing up into our lungs. So once we have that, we have pulmonary effects. So we're thinking like pulmonary congestion, dyspnea, orthopnea, you might hear crackles, pulmonary edema. All of those things are because your left ventricle can't pump blood. Because it can't pump blood, it's backing up. And so some causes of left-sided heart failure can be undiagnosed or untreated hypertension. So what happens is that your ventricle gets so tired of having to pump against that increased afterload of hypertension that it just starts to kind of give out. Another one could be a myocardial infarction. So say you have an MI, you block off blood supply to the left ventricle, and even though you heal and you survive, your left ventricle is not ever going to work as well. Or you can have things like valvular disease. So maybe your mitral or aortic valve is not right. All right, then we have right-sided heart failure. So thinking this area right here. Hold on. This area here is damaged. So what most often happens here is we have a right ventricle that's failing. And so some of the effects that we see here are some systemic effects. So we talked about JVD, jugular venous distension, where your heart, same thing, the blood starts to build up, but then instead of it going into our lungs, it goes back up into our jugular vein. We can also have hepatomegaly or splenomegaly, right? That's just because our blood is backing up into our system. Definitely you'll have peripheral edema because all the blood's backing up. Ascites. And so some of the causes for this, most common is left-sided heart failure. So normally left-sided will cause right, but also it could be from things like pulmonary hypertension. And so the same thing there is that you're kind of increasing, the afterload for your right ventricle because if your pulmonary artery is congested, you have force pushing up against it when it's trying to push out. And that will cause your ventricle to be very messed up. Or you could have a right-sided MI for the same reasons. Your right ventricle would stop functioning. Okay. And I have this chart for you in case you like that. And that's it.